Well, I've seen, and I wanted to ask you about this too. I've seen people who identify with a range of symptoms that are now characterized as long COVID. And that could include that, what you just mentioned, is that same experience. What do you know about long COVID and potential results of that?
Sure. So if there's damage to the pulmonary vasculature, there's going to be a set of symptoms you get. And you're going to notice it the more exertion you do. And so the physiology simplified is this. As you and I are speaking, blood is flowing to your right heart through your lungs, through the left heart at about 5 liters a minute. The pulmonary vasculature is wide open. If you spread it out, it's thought it would cover the surface area of a tennis court. So it's a very high flow, low pressure system. And the right heart is oriented with longitudinal fibers, so it responds very well to changes in volume. So if you stand up so quickly, it doesn't bother you. Or if there's a sudden blood return to the heart, it'll absorb it. The left heart is designed with concentric fibers to pump a high pressure. If you're an athlete and you exercise, it is possible to get your blood flow through the right heart, through the lung, to the left heart, and then out to the tissues, 25 liters, 30, 35 liters a minute. So it's such that blood can be traversing 1 liter through your pulmonary vasculature every 2 seconds. It's incredible physiology. But anything that is going to impair that blood flow through the lung is going to limit the flow through the left heart, and it's going to impair your ability to exercise. It will decrease your aerobic capacity that's measured by VO2 max. And I can see, so what happened to me was I felt very, very ill, and the pressure in my lung was high, and my ability to exercise was severely impaired. It was hard for me to even stand. It was hard to walk even. 3 miles an hour would be a big exertion. People describe me as ashen, gained a lot of fluid, 15 pounds of fluid, felt like I had a headache all the time, and the fatigue was simply overwhelming. And any kind of exertion, I just get this pressure in my chest. That very uncomfortable. It was about 4 months before I could even lie down and be comfortable. So the misery is just so hard to overstate. And I survived it. But what's amazing is that 1 year I thought, I am surely going to be one of the very rare people where this pulmonary hypertension has reversed, because I'm able to do more stuff. I was able to walk hills, even run very slowly, not great, got back into the circus arts slowly. And that 1 year, the pressure had not changed. Over 3 years, I have more endurance. I could do more things. I can run some. I can ski again. I can go to altitude, which is a big no-no, supposedly, with pulmonary hypertension. But I'm able to do it. I still have this high pressure. And the amount of lung vasculature I have lost is the equivalent of if I had a lung taken out. It's what you'd expect after a pneumonectomy. And it's hard to convey this to people because you're probably looking at me like, he doesn't look unwell. I had a lot of damage. And this is hard to convey to people out there who say, well, I got this product and I'm probably fine. And I ask, well, how do you know that? Are you sure? And it is just stunning what I see in my practice among staff and patients is how many people are short of breath doing things, and they end up either going to a lung specialist, and they will have normal pulmonary function tests, but maybe come out with a diagnosis of asthma even though they've never wheezed.
So it gets attributed to other causes?
Other causes. Or they'll see a cardiologist, and the left heart is pumping fine. They'll even have a clean stress test. The arteries that feed the heart are fine. And there's a shrug. There's a lot of arrhythmias that come. I had a lot of arrhythmias early on too, palpitations, which has since passed. And I'll look on the echocardiography report and I'll see near diagnostic or close to diagnostic pulmonary hypertension. And the reason it's so confusing to doctors is we need a better name, because the problem is it's impaired flow through the lungs, okay? And it will be labeled mild pulmonary hypertension. And even though mild pulmonary hypertension doesn't sound bad, but you're still talking with something that has a life expectancy of under 7 years and usually progresses. And it's very hard to convey the seriousness to even other doctors, let alone people outside of medicine. So my premise is that of anything that's going to impair blood flow through the lungs, if there's a narrowing of the vasculature, if there's an overgrowth of pulmonary arterial cells, that any impaired blood flow is going to be first noticed by the athletes, and you typically see this.
And we have seen that.
You have seen it. And most of the athletes I know would say, oh, my times are much slower now. The wattage I can do on a cycle is down. And they would usually recover over a few months. But what was really interesting, and this is the point of long COVID, is there was one group that looked at long COVID patients who were short of breath doing things. And it's a small study, and I sent it to you. It's the one from Italy. And it's only 20-some patients, but every single patient in that study had pulmonary hypertension. And the reason this is so remarkable is that if you have acute pulmonary hypertension to the point you make the diagnostic threshold, or the pressure they define as a mean pressure in your lungs of 20 millimeters of mercury, used to be 25, they lowered it. But if I were to do that acutely to you, if you were to throw a blood clot to your lung, you're on death's door. Many people will not survive that. So by the time, if you have, usually pulmonary hypertension would come on over years and would give the right heart time to adapt. When it happens acutely, your right heart does not have time to adapt. Now, if you're an athlete, you have a better chance because your heart has been working, doing more pressure and volume work. So really trained athletes will actually have a little right heart hypertrophy, and that's probably what will save them. But what was remarkable in that Italian study is that at 1 year, they followed these patients with long COVID, and over a year, they got a little better. They could do more stuff. They could walk further. They felt better. And they would go and measure them, and they were using the gold standard, which is using a right heart catheterization. So they measure the pressure directly in the pulmonary artery and in the right heart, and they still had pulmonary hypertension. And so it is possible we've had a sea of damage out there. What's unknown, and this is with people who had COVID, okay? So the question next is, and this was Dr. Suzuki's hypothesis, well, we're seeing this in COVID. If you look back, and he was researching that because he was looking at SARS. It was known with SARS-1, if you just took the spike protein component, you could recreate the disease in the animal without the virus attached. It would cause the disease. So that's why he thought to research that. And then we see pulmonary hypertension in the autopsy. We see lung vascular damage in the autopsies. You see it in the tissue culture that he was using. And then I'm the human correlate of that. And the question is how much out there? Am I unique? Or is this something that's broadly happening to people? And so
You're
this
a
is
case study.
I'm the first, yeah. So, so the question is am I very unlucky, or I'm an example of a spectrum more severe, but a spectrum of things that's happening? And then the next question is this an inherent property of the spike protein? And what's very worrisome is that there was a study with middle-aged cyclists with who were trained cyclists with, for their age, a good VO2 max, a good aerobic capacity. And they gave them a booster shot, and they measured their aerobic capacity 1 week after the booster, before and after. So presumably they had already had mRNA product, and they were using, I think, the Pfizer mRNA. And at 1 week, that group in aggregate had a drop in their aerobic capacity that was what you would expect to see of 5 or 10 years of aging. And what's unknown, and I wrote the authors never heard back, like, well, why do you think this is? It's some impaired oxygen delivery. Either blood's not going through the lung or mitochondria is not using the oxygen. There's some problem. And does it get better? And as to my knowledge, that there's no answer to that yet. And then most worrisomely is the current research at Georgetown, where if you just replicate the experiment with SARS-1, instead with mice, we're using rats this time, and you take just spike protein, no adjuvant, and inject it into the abdomen, the peritoneum of the rat, you could induce vascular damage, profoundly so. And so I hope this study is published. It should not be hard to replicate around the world. It's not particularly difficult. You're seeing pulmonary vascular damage, right heart compensation. There's some changes in the heart muscle. You alluded to before, we weren't looking at placenta, but it's known that human placenta is damaged from COVID, from SARS-2. And there are one of the collaborators with this, who the cardiologist, pathologist, looked at the brain slides of the experiment, and the same process is happening in the brain.